On October 10, 2012, the Health Council of Canada welcomed over 375 delegates to its annual symposium, Advancing Integrated Healthcare in Canada, Practices That Work. Councillor Dr. Charles Wright helped leaders explore the best paths to find solutions for achieving integrated care in Canada. Members of the panel were Shirlee, Sharkey, President and CEO, St. Elizabeth Healthcare; Joan Park, President of the National Case Management Network of Canada; Dr. Paul Sawchuk, Chief Medical Officer, Concordia Hospital; and Dr. François Béland, Professor in the Health Administration Department, Université de Montréal, and co-director of SOLIDAGE, McGill University, Université de Montréal Research Group on Frailty and Aging.
The particular discussion for this panel is to be focused around what we've called minding the gaps, trying to find solutions for achieving integrated care in Canada. We would like to identify what the major challenges are in implementing integrated care in Canada and identify practical solutions. The question is this. As we've said many times, we know a lot of what has to be done. What are the challenges of implementing integrated care in Canada today? What are the potential key solutions for overcoming the challenges? And we would appreciate focusing the answers on the most fixable gaps. Where can we make the most headway in the nearest future? So with that, I will ask Dr. Sawchuk to commence.
Good morning. In my few minutes, I'm going to focus on the importance and challenges of supporting interdisciplinary teams in the community. As Charles said, I'm a family physician, the Chief Medical Officer of Concordia Hospital, a community hospital in Winnipeg, site medical leader at Access River East, which is a community health services organization, part of the Winnipeg Regional Health Authority. I come to the issue of integration from my positions as both a hospital administrator and a frontline worker, with experience in a small virtual ward demonstration project. Our virtual ward project only focused on a handful of very high-risk individuals, but with no additional resources and just relying on more intensely coordinated teamwork, we were able to decrease the utilization of hospital resources by over 50% in this group. It made me a true believer that increased development of community services would allow us to scale back our more expensive hospital services. Further integration of our healthcare system relies on the further development of our community services, which in turn relies on the increased effectiveness of interdisciplinary teams in the community. In intensive care units, emergency rooms, and operating theaters, there is an established tradition of effective interdisciplinary teamwork. However, strong, engaged, effective teams are much less established in the community, where they face unique barriers. For integration to be optimized, these barriers need to be identified and addressed. One of the most obvious barriers to interdisciplinary teamwork in the community is the physical disbursement of its team members. To function at a high level, teams need familiarity, trust, and shared experiences. This can be difficult to come by in the community, where, in direct contrast to ICUs and emergency rooms, community team members are spread out over a space that is not measured in square yards, but in square miles. Team members don't get as much of a chance to see each other face to face, drink coffee, and discuss clients. A second issue is a relative lack of system support. As someone who works in the hospital and community on a daily basis, I'm regularly impressed by the resources that can be brought to bear within minutes for a hospital patient, while those same resources can take months to organize in the community. If you want to consult an internist or a speech-language pathologist on a hospital patient, just pick up the phone and your patient can be seen before lunch. In the community, your patient can be seen before Christmas, if you're lucky. However, I think the largest issue that community teams face is the lack of a unifying vision that affirms their place in the larger healthcare system. Too often, issues break down into a silo mentality, with the emergency room versus home care, with hospital versus the community. Hospitals and community have some regrettable history with regard to not supporting each other willingly. Inside of our hospital, we would never transfer a patient from one ward to another ward without a written transfer note, a phone call, and mutual agreement. However, we do that all the time when we transfer people back into the community. Members of a team need to share purpose, need to have a unifying vision. In the community, it's rare to have lives acutely hanging in the balance. We can't rely on the compelling acuity of the human story sitting in front of us to inspire effective collective action. On the other hand, the sustainability of our healthcare system does not rely on improving the effectiveness of our emergency rooms or improving the effectiveness of our surgery programs, but it does rely on developing the effectiveness of our community teams. I think it's safe to say that with the possible exception of hockey, our healthcare system is the most important component of the Canadian national identity. I also believe that the future viability of our cherished publicly funded healthcare system relies on improving the effectiveness of community care. You would think that for an issue so central to who we are as Canadians, we could articulate a sufficiently compelling vision that would have every healthcare funder and every healthcare worker breaking down the doors so they could participate in the development of solutions. But as much as I see a need for the unifying vision, I have many questions with regard to the scale and origin of the vision. If the scale is too big and too faceless, I fear for the alienation of the frontline workers. A balance needs to be found between the larger system and the individual workers. In our experience, we've had some success rallying workers around a vision for our community area, a neighborhood of about 100,000 people. I'm not sure how to expand beyond that. Once we have our compelling vision that affirms the importance of community work, we will need to back this up with appropriate resources. One positive example of this from our jurisdiction in Winnipeg is the development of access centers. Access centers are home to home care services, public health, income assistance, child and family services and housing, as well as primary care. Access centers serve as a physical and philosophical hub for doctors, nurses, social workers, and allied health care team members to meet, discuss, and plan. Our Access Center served as the home for our virtual ward. Access centers are an essential component to our integration efforts in Winnipeg. After the vision and resources are in place, we will need to pursue a change plan to break down the historical silos. Workers at all levels and parts of the system need to understand the importance of their role in the system. We'll need to see that the work they are doing is an important part of the larger whole. That they are accountable, yes, to their patients, but also to the larger system, and the larger system is accountable to them. What is the responsibility of the home care worker to the ER physician? And what is the responsibility of the ER physician to the home care worker? In a properly integrated system, these two individuals see themselves as team members accountable to each other to serve the patient and the larger community. In a hospital setting, as I said, your bedside workers and medical staff get a chance to meet, get to know each other, develop rapport, and work on their teamwork. We need to learn to do this on a wider scale for staff who don't work in the same building. We need to learn how to apply all the things we know about team building to people who currently never get a chance to even meet, never mind bond. During our virtual ward demonstration project, we put considerable focus on interdisciplinary team development. Simple things like taking the time to meet face-to-face, committing to eat lunch together at least once a week to discuss patients and establish the processes that make teams effective. As we scale our virtual ward efforts up to include more patients and more workers, we still have some team building to do before we can say we're on our way to effective integration.
Thank you, Dr. Sawchuk. Joan Park.
It's a pleasure to be here today and to speak about the future and the promise of case management as a vital and dynamic strategy for our healthcare system across Canada as we all age, as we all live with chronic illness, and as we survive catastrophic injuries. As Romano identified in 2002, case managers will become an increasingly important role in coordinating care with a team of healthcare providers. One challenge to implementing integrated care may be the starting point. If full integration includes funding, administration, organization, service delivery, and clinical care, I suggest that we start the conversation by leading with clinical care and service delivery to define the organization's administration and funding formulae required. In other words, rather than it being boardroom to bedside, I believe it needs to be bedside to boardroom. Let me give you an example. The cost of care is often perceived as a challenge to implementing integration. My question is, are we identifying the right cost? In the case management world, when you provide the right care in the right place, at the right time, by the right provider, the right cost is achieved. With that knowledge of the right cost gleaned from the bedside, the boardroom can better determine the funding formula. Similarly, understand that while you integrate systems and operations in the boardroom, it's at the bedside that you coordinate care. Coordinating care is the central role of case management. Case management providers are leaders in coordination and facilitation and experts in health and social needs planning. Case management starts with an assessment. It's a holistic assessment of what that individual client's needs, wants, and dreams of living a fruitful and productive life. It's an all-inclusive assessment of their health and social needs. I think that's where the strength of case management lies, in pulling together the health care and the social service needs of an individual client or population. Case management is defined as both a process and a role. The National Case Management Network in 2008 developed Canadian standards of practice for case management that define the collaborative, client-driven process for the provision of quality health and support services through the effective and efficient use of resources. The case management process supports the client's achievement of safe, realistic, and reasonable goals within our complex health, social, and fiscal environment. In 2012, the National Case Management Network tabled the Canadian Core Competency Profile for Case Management Providers that describes the central role of case management leader and the interconnected roles of communicator, collaborator, navigator, advocate, manager, and professional. Based on this Canadian common body of language and knowledge, frontline case management providers deliver concrete and actionable care and services that are broad enough to encompass the diversity of the professional backgrounds and working environments they practice in. Across the country, Canadians, especially those with specialized, complex, and chronic healthcare needs, experience limited access to and gaps in healthcare. Every episode of their care involves various individual providers and transfers between care settings. Case management providers are the dedicated healthcare providers who strive to meet the care coordination issues. Case management providers coordinate care within and across health and social sectors. Case management providers are collaborative leaders, outcomes managers, and multidisciplinary clinical experts with system savvy. With an unwavering commitment to quality, they are at the center of coordinating care that is accessible, acceptable, appropriate, equitable, efficient, and effective. Keeping in mind that Canada's National Health Insurance Program is designed to ensure that all residents, blind to income, fixed on need, and measured by the standard of care that we set for the least privileged people among us, to provide those health services, integrated care is seen as the answer in the boardroom, but my feeling as the president of the National Case Management Network is that case management practice at the bedside is the key component to a client-driven process that ensures the delivery and sustainability of integrated care.
Thank you. Right on time. Just a reminder that we're not taking questions until each of the panelists has had a chance to speak, so please make notes and be ready to ask them at the end. Shirlee Sharkey.
Thank you, Charles. And good morning, everyone. It's great to see so many familiar faces. If anyone knows me well, they know I have absolutely no impulse control. So I always want to know what the last chapter of a book is before I start to read it. I want to know the punchline before I'm listening to the joke. So I thought, you know what, I'll start with the solutions and then I'll work backwards. And the ones of you that have the same condition that I have, hopefully you'll be calm. But I have really two solutions. The first one being that I think we have to engage more people in the conversation of what we're talking about when we look at changes to the system and integration. And we need different people, new thinking, different perspectives, a group of people that I would actually call amateurs. People who are not typically at our table to help us with new ideas and decision making. So that's solution one. Solution two is we need to redefine what we mean by accountability. And by that I mean a balance between empowerment and a balance between accountability in a way that I would define one that identifies trust, respect, and mutuality. So now, let me give you some context for those two recommendations. I think we've heard a lot about integration, and I think the good news is it's an idea that everyone embraces. The bad news is that if time is a measure of success, we've been too slow to make this all take place and other terminology to stick and to really work for people. And I think creativity and collaboration is a lot of heavy lifting. It's a lot of messiness, a lot of ambiguity, a lot of risk-taking. Sounds like the healthcare system? No. So I think because of that, what we do is we move into the mode, all of us, of trying to understand more with the best of commitment to what we're trying to do and the greatest of passion. But we move to, we've got to understand this and we've got to control this. And so we have to know what's going on, who's in, who's out, what do you do, what don't you do, how does the structure make sense? All of those phenomena that we're simply wired to move into that mode. And I was recently reading Ted Ball's, I don't know if Ted is here today, his blog on accountability, and he had on that the illusion of control that I guess a wonderful organizational leader quoted, but I'm calling it a psychosis of control that we have, in healthcare. It's always, who owns this? Who owns the care? One singular point. And when I really reflect on people and communities and their home and the world that is not in the center of a healthcare system, none of us are about control. We are all about our empowerment, our decisions, our realization. We walk into the healthcare system and it becomes a very different phenomenon. So that's why I started with my solution of bringing new people and bringing amateurs into the discussion and figuring out very creative ways to have those conversations at the community level, at the health system level, at the planning tables, and yes, at the government levels. I think that our vision of what we're trying to achieve when we look at integration is a bit confusing for me, because if it's really about what type of experiences we're trying to create for people, and what do they need and want in their health journey, where so many times that has nothing to do with the health system and everything about their lives, how and our starting point needs to change. If we're talking about emergency room diversion, ALC, and duplication, and redundancy and costs, that's a different starting point. So I do think many times our activity is not necessarily complex or confusing, it's not aligned because we really haven't landed ultimately what we're trying to do with this component of integration. When I look at redefining accountability and really looking at, we could call it courage, but I think it's a different concept of trust and respect for the strengths of all people in society, and not just the healthcare system, but all people in society. And we see it everywhere else, where we now know solutions to things are much bigger and broader and collective than our little world, and we have the luxury of that being at our fingertips. So that is, I think, another component that starts with fundamentally having trust, respect, and faith that we're actually going to come up with solutions at all levels of not only our healthcare system and our government, but as society at large. And when we really think of it, integration is in fact a means to an end, very simply to make the world a better place. And I think if that's the vision, then we can all fall into the alignment piece.
Thank you very much, Shirlee. François Béland.
Bonjour. Le docteur Conner nous a précédés et a dit plusieurs choses qu'on voudrait tous entendre. Il y a une chose qui m'a frappé lorsque j'ai entendu la question, c'est-à-dire quels sont les défis et quelles sont les solutions. C'est que si vous relisez la littérature correctement, vous allez vous apercevoir qu'au moins depuis les années 1970, c'est le siècle passé, ça, 1970, hein, toutes ces questions-là avaient été soulevées, le type de population qui ont besoin de services intégrés, les composantes dont ces personnes avaient besoin, ce qu'il fallait faire. Le programme PACE, je crois, a commencé dans les années fin 70-80 au moins. Donc, il est surprenant qu'après une quarantaine d'années, à peu près 40 ans, nous en soyons encore à nous demander quels sont les défis et quelles sont les solutions. Ça fait 40 ans qu'on connaît les défis et qu'on en parle, n'est-ce pas? Alors, pourquoi? La vraie question est plutôt pourquoi est-ce que nous en sommes encore à nous demander des questions qui sont finalement les toutes premières questions et auxquelles il y a tellement d'articles qui ont été publiés que même dans ce qui me reste de vie, je ne réussirai pas à toutes les lire. En fait, ce que je crois, c'est que en ce qui concerne les services intégrés, on est au cœur de la question. On ne parle plus de structure, fondamentalement, on ne parle plus de structure, on ne parle plus de financement, on ne parle plus d'organisation, on parle de ce qui se passe entre un patient, ses proches et les professionnels de la santé. Et je crois que c'est là, précisément, oui, le véritable problème. Le problème n'est pas dans l'intégration, le problème n'est pas dans notre incapacité de réflexion. Le problème est dans le fait que nous en sommes à ce que les professionnels eux-mêmes pratiquent et à la propriété que les professionnels de la santé, n'est-ce pas, conçoivent. Les professionnels de la santé conçoivent que ce qui se passe entre le patient et eux sont leur propriété personnelle. Je crois que c'est le cœur du problème et je ne crois pas qu'il y en a d'autres. Il y avait une ADM, une sous-ministre de la Santé de Colombie-Britannique, qui, placée devant une question sur l'intégration, a dit, et je crois qu'elle a raison, au Québec en tout cas ça se vérifie, les ministères de la Santé au Canada sont capables de faire deux choses. Premièrement, modifier les structures et deuxièmement, soit garrocher de l'argent, lancer de l'argent au système ou encore couper de l'argent au système. Mais en dehors de ça, les ministères de la Santé n'osent simplement pas agir. Et l'intégration des soins, comme l'a dit le Dr Conner, si vous commencez avec la structure, vous allez vers une catastrophe. C'est vraiment pas là qu'est le problème. Intégrer les structures, qu'est-ce que ça fait? Bon, ça va faire mal à quelques CEO, des directeurs. Ça va faire mal à quelques comptables qui vont perdre leur emploi. Aussi, évidemment, il va y avoir des administrateurs qui vont devoir administrer le changement de structure plutôt qu'administrer les soins. Remarquez que pour un ministère, c'est absolument parfait, parce que pour un ministère de la Santé, c'est beaucoup plus simple d'administrer des structures qu'administrer des soins. Aussi, n'est-ce pas, une autre chose que les ministères font, c'est lancer de l'argent, mais d'autre part, penser des moyens de financer de telle sorte que l'intégration puisse se faire est une chose qui apparaît totalement impossible et hors de portée des ministères de la Santé. Je pense actuellement à ce qui se passe dans le financement des hôpitaux. À peu près toutes les provinces, en tout cas un très, très grand nombre de provinces, sont en train de repenser le financement des hôpitaux. et veulent le changer de façon radicale, de telle sorte qu'il y ait maintenant activity-based financing. Hein? Alors, on va financer les hôpitaux à l'acte. La plupart des mandats donnés par les provinces à des groupes de travail pour repenser ce financement des hôpitaux impliquent qui? Les ministères des Finances et les conseils du Trésor, les Treasury Board. Are there anyone here from Finance Minister or Treasury Board ministers from the provinces? Where are they? Maintenant, est-ce que dans ces groupes qui sont en train de repenser le financement des hôpitaux, où à peu près pas loin de 50% des séjours hospitaliers actuellement sont de la part de personnes âgées avec de multiples maladies chroniques qui ont besoin de soins intégrés, qui sont celles dont a parlé le Dr Cotner, combien de ces gens sont en train de se demander quel va être l'effet d'un financement des activités hospitalières par activité sur la capacité du système de donner des services intégrés? Personnellement, j'ai lu un certain nombre des papiers et il n'y a strictement personne qui se pose la question. Or, les services intégrés, comme on l'a dit ici, doivent partir d'où? Ils doivent partir effectivement. On doit commencer à les penser. Alentour de ce qui se passe dans la clinique, dans la pratique clinique, autour de la personne et de la personne âgée, la plupart du temps, de la personne qui a des problèmes complexes, de son environnement, du rapport de cette personne au prestataire de soins, quel qu'il soit, et à partir de ce que l'on veut faire là, on doit penser quelle est la meilleure façon d'organiser le système pour que l'intégration arrive et quelle est la meilleure façon de financer le système pour que cette intégration arrive. Actuellement, on a fait exactement le contraire. Les ministères ont toujours fait le contraire et les ministères continuent à faire le contraire. Les ministères ont effectivement une relation presque amoureuse avec les changements de structure. Au Québec, par exemple, on a eu des commissions d'enquête et à peu près tous les 10 ans, on change de structure. Le dernier changement de structure, c'était en 2003, où on nous promettait une intégration du modèle clinique par l'intégration des structures et du financement. Je vous laisserai faire des détails. Heureusement, lors de la dernière élection au Québec qui a eu lieu dernièrement, il y avait un parti que je nommerai pas qui proposait un autre changement de structure. On aurait eu à ce moment-là l'histoire qui aurait continué, n'est-ce pas? 10 ans après la réforme de 2003, on aurait eu encore un changement de structure. Heureusement, ce parti a été battu. Aux dernières élections, nous n'aurons peut-être pas un autre changement de structure. Mais je vous garantis une chose, malgré ce qui se fait, malgré le travail important, extrêmement intéressant dans certains secteurs, au Québec, probablement que dans 5 ou 10 ans, nous n'aurons pas des services intégrés pour les personnes âgées.
So, I'm going to right away invite questions. I have a number in case the conversation gets lax, which I'm sure it won't. But let's start by giving the audience a chance. I am going to not only ask but insist a preamble to a question is acceptable, a speech is not. So keep your preamble focused and we'll be delighted to deal with your question. Yes.
I'm Shalom Globerman. I'm president of the Patients Association of Canada. And it's interesting how you began to talk about patients finally a little bit. And what I found interesting also was the fact that structural change, that when François was talking about structural change, he says it makes no difference. But in fact, in Quebec, when they did the last structural change in 2003, they closed the CLSCs, which were one of the hopes for integrated care. So actually, they made it less integrated by changing the structure. I think that that's an important thing. I think that one of the things that also should be said here for this is, especially for the issues that you raise, is talking about not just the role of patients, but the role of patients and their families in beginning to integrate care. That it's not simply the interaction between patients and professionals, which is what you've all been talking about. It's actually the interaction between patients and their families and professionals, especially in the cases of older people with complex conditions. And the failure to take into account the role of caregivers and the cost to caregivers in the system is really important. So a lot of times when these structural changes occur, the saving in cost that occurs to the system is actually not a saving in cost to the society, it's actually a transfer of cost from the system to families and caregivers to take care of the patient. I think that this is something that I'd like you to talk about. Thank you.
Thank you for your comment. François, do you want to make any comment on that?
Yeah, well, what you're saying about CLSC shows that structural changes doesn't work, because the goal of the Couillard reform was to enhance integration of care locally, such that now in Quebec we have 95, now there's 94, called Centre de Santé et de Services Sociaux, which actually, well, the whole idea was nice. On the value of the project were okay, were well oriented. It was that those C3S were to have the responsibility of care and the responsibility for the health of the population living on the territory. And the financing, the idea was that the financing would go to these C3S, and the global financing, the C3S would have had the global financing for hospital, nursing home, and CLSCs, and they would have, the C3S would have the whole responsibility for this. Now, in some cases, it did work, but it didn't work as expected in most of the cases. But the goal was this. And I remember the Ministre Couillard. You say no, but I remember the Ministre Couillard. We met with Minister Couillard at that time, and then he complained, no one is talking about my clinical model. So we asked, we told him, what clinical model? Where it is? And they still are looking for the clinical model 10 years after.
Thank you, François. Any of the other panelists want to have a go at that? Shirlee?
Yeah, I wanted to, Shalom, challenge your thinking a little bit, actually, and to say that I think when we're looking at the whole concept of integrated care, and how this morning we heard of all of the various levels, from self-management through to very complicated navigation, coordination, and integration for complex people, I actually don't think it's about patients and families. I think it's about people and families and community and society at large. And I believe it's a larger societal conversation of how we want to deal with an aging population in Canada. And then we look at all of the facets, and certainly our stage as health providers is looking at that integrated component. But it's a different starting point. We started it as a health system, put the patient and family in the health system. We live in a social system, and the health system's interface plays on very differently. And I don't think we ever have that different starting point. I know you agree with me. So it's really a matter of where do we start the conversation, and absolutely. But I think our end point might look different if we actually look at the strengths of communities, neighborhoods, people, homes, society, culture, churches, all of that world. Then we superimpose that into our world of the health system, and how we design things could play out very, very differently. It'll be messier. It'll be more difficult to have that sold to the public, but I believe that would really make a very different endpoint.
Thank you. I think we'll move to this microphone. Next question, please.
I wanted to leap off from where Sharkey just ended off by saying that one of the things that we haven't talked about in this room in integration is really possibly one of the white elephants, is that Canadians have been very well known for doing excellent research on the social determinants of health. And we've really clearly articulated and very clearly shown the evidence for promoting equity in our social structures, for promoting equity, particularly income equity and social status inequity. And what we really, really lack is the integration between that huge social system and our healthcare system. And it's so important that those of us who work in the system are able to talk about that, because particularly people who are ministers of health or people who work in the system often say that all of those things are beyond their control. If we really do want to encourage integration in our system, there's got to be a much better way of integrating that. And I think Dr. Béland referred to that we've known all of these things for so long. In 1974, Canada was one of the signatories to an important Alma Ata document that said we need political will, we need intersectoral collaboration, and we need intrasectoral collaboration. And
Do you have a question?
Yes, so I just wanted to comment on that one topic of integration of society and the healthcare system.
You talk about the determinants of health. There is, of course, a very depressing aspect of that discussion because the healthcare system in general ranks very low on the hierarchy of all the issues which determine health in communities. Sorry, that's just a depressing note for you all. A note of reality that we have totally forgotten in the way we have built the healthcare system in Canada, now consuming 11-point-something% of the GNP. Anyway, that's for another debate. So, anybody want to respond to her comments? Yes, Joan.
Comment about the intersectorial relationships, but certainly that's the world I've been living in, talking to case management providers across the country, and we keep adding to those sectors, right, of FNIH and mental health and D&D and VAC and rehab and private insurance and primary care. So what we find as case management providers is that we do act with each other across those sectors, trying to make it all work.
I just wanted to say that those inequities that exist in our society are also the inequities that lead to our greater need for courage to deal with the hierarchies within the healthcare system itself. Those inequities really are where our need to be brave lions come from.
Thank you. This microphone?
Deborah Kopansky-Giles. I'm from the Department of Family and Community Medicine at St. Michael's Hospital. And I wanted to reinforce some of the messaging that we've experienced that have been coming from the panel in a positive way. And that is especially your remark, Shirlee, about being creative and innovative and bringing different partners and different thinkers to the table. We're really proud that our department was identified as one of the 4 primary care sites in the Healthcare Innovation Working Group document that was recently produced by the Council of the Federation. And where we came from was involving patients early on in the discussion about what they needed in primary care. And as many would know, that St. Mike's is an inner city hospital dealing with many vulnerable populations and really complex cases. We actually had a lot of creativity in bringing in services that were not typically delivered in a hospital setting in primary care. For example, we have 10 different health professions working in our department, including chiropractors, psychologists, and dentists. And each of those groups brought in creative funding solutions. And so we have funding relationships among 5 different funders from the Ministry of Health, University of Toronto, Ryerson University, the chiropractic profession in Ontario and their college, and Toronto Public Health. And those funding solutions enabled us to be innovative in building a program that patients can access services free of charge, and they're sustainable. So I did want to reinforce the importance of bringing creative thinking. The challenge that we still have is how do we make sure those relationships and the funding solutions are long-term and sustainable? And how do we throw it back to policymakers on making sure they get those messages?
Thank you for your comment. We have a question here.
So if we are to live for real the principles of primary health care, which our colleague and others have spoken about, where is best to locate the tremendously important function of case managers and system navigators? Is it in the hospital, which I will suggest not? Is it in primary care, or is it in home care? Netherlands, for example, is in home care. In other places is in primary care. Can you give us your views on that, please? Because the role is essential. The question is where is best located to actually bring those social determinants and other services to life.
Thank you. Joan?
It's interesting as I talk to people across the country on Lunch and Learns, primary care has been the topic that case management providers themselves are bringing up. There's a young lady in Brantford I can think of on a phone call here in Ontario who's working with a primary care office, and she says, this is where it's at. And I've worked in hospital sector for many years, and I always say, if I leave St. Michael's tomorrow, I'm going to go and talk to a family physician in group and say, you need me. So I think family physicians or primary care There's a role for NPs, that's the clinical care side, but there's so much of this care coordination, service delivery, networking. So I think there's a role for a case management provider to be built into a family practice.
Dr. Sawchuk?
I would say from our experience, it would need to be a combination of the both, that I'm here today with people from our organization, from both the primary care side and home care side. And we are looking to find a different language for that so that it isn't one side of a team versus another side of a team, but that we actually see each other as genuine partners and members of a team. So some sort of community care language that primary care, family physicians, et cetera, can be part of. And I think that Dennis Codner earlier said, you do have to engage the family physicians. They do need to be part of this story. Lots of the resources in our jurisdiction are also in home care. So we have, in our clinic, we have 60 home care nurses. So we need to be able to match those 40 family physicians in our private practices in our neighborhood and those 60 home care nurses and have them feel like they're part of one team. And we don't have the solution to that. We're working on the solution to that. But to me, we can't choose between one or the other. Our answer has to be both, and we think that's where we're going to go.
Thank you. François.
Le docteur Codner a dit quelque chose d'important. Il a dit start where you are. Alors, je crois que c'est très difficile de répondre à la question de façon universelle où, par exemple, une composante d'un système intégré très importante, évidemment, comme la gestion de cas, doit être située. Elle va être située là où c'est possible de la situer, étant donné le système que vous avez, étant donné ce que vous voulez faire avec le système intégré. Maintenant, le gestionnaire de cas, et je crois que le Dr Codner l'a bien démontré, est un élément d'un système intégré. Il doit y avoir une équipe multidisciplinaire. Il doit y avoir aussi des gens auxquels il y a une population auxquelles s'adressent les services intégrés. Les services intégrés, en tout premier lieu, sont pour les cas complexes, avec de multiples maladies chroniques, des incapacités fonctionnelles. Souvent, on va y trouver de la dépression et aussi des problèmes cognitifs à différents niveaux. C'est donc cette population-là qui a besoin de services intégrés. Et aussi, un service intégré ne peut pas fonctionner si les gens responsables du service intégré n'ont pas cette responsabilité vis-à-vis ces gens-là, le mieux, c'est vis-à-vis les gens qui, sur un territoire, comme le dit d'ailleurs le Dr Sawchuk, un territoire doit être relativement petit, mais pas trop. Il doit y avoir une responsabilité de population. Alors, prenez tous ces éléments-là, demandez-vous où dans votre système un truc intégré pourrait fonctionner, et là, vous allez savoir aussi où devra être localisé le gestionnaire de cas. En ce qui concerne SIPA et en ce qui concerne le Québec, nous, à cette époque, il y avait encore des CLSC quand on a fait SIPA. Et pour nous, il était clair que l'équipe multidisciplinaire qui avait la responsabilité pour les patients du territoire, les personnes âgées et leurs familles du territoire de CLSC devaient être dans le CLSC, mais il y avait toutes sortes de liens qui se créaient à ce moment-là entre l'hôpital, les nursing homes, les centres d'hébergement, les centres de jour, etc. Et c'était le gestionnaire de cas, entre autres, qui avait la responsabilité d'établir ces liens. Donc, difficile d'avoir une réponse, et c'est, la difficulté de l'intégration, mais la beauté aussi de l'intégration, c'est qu'il est possible de l'adapter à l'état du système dans lequel vous êtes.
Thank you. This microphone, please.
Professeur Béland, vous avez parlé des changements structurels que les ministères font, et puis on en a vu beaucoup, on refait des structures. Et je me demandais si vous pensez qu'il y a de manière générale, à tous les panélistes, si vous pensez qu'il y a des modèles quand même qui promeuvent mieux l'intégration des soins, et s'il y a des modèles de financement également. Donc, justement, en ce moment, dans le contexte des ministères qui songent à la tarification à l'activité pour les hôpitaux, est-ce que vous pensez que aussi certains modèles de financement sont plus favorables à l'intégration des soins que d'autres?
Oui, certainement. Maintenant, le modèle de financement, vous voyez, c'est que quand on parle d'intégration, le problème souvent, c'est que la première des choses, on va penser à une intégration des structures. Donc, on va tout mettre en même temps, tout en même place, puis on va tout financer un peu en même temps, un peu comme au Québec avec les C3S. Alors, on a mis les hôpitaux, on a mis les nursing homes, les centres d'accueil, on a mis les CLSC, puis on a dit on va financer tout ça. Évidemment, ça marche plus ou moins, puis il y a des endroits où ça ne marche pas beaucoup. Mais ce qui est important, c'est que, c'est un peu comme l'a dit le Dr Codner d'ailleurs, c'est qu'il y ait sur un territoire un groupe de personnes reconnues responsables pour l'intégration des soins, ce groupe de personnes doit avoir les ressources financières. Ce groupe de personnes doit contrôler l'argent, doit être responsable de l'argent. Et là, à partir de ce moment-là, vous pouvez avoir toutes sortes d'arrangements. Alors, supposons que vous avez des groupes reconnus sur un territoire, sur les territoires du Québec ou de l'Ontario, qui sont responsables de l'intégration des soins pour les personnes âgées fragiles. Tout l'argent du système va à ce groupe. Les médecins, les hôpitaux, les nursing homes, la pharmacie, enfin les médicaments, les services à domicile, tout, ça va là. Ils contrôlent l'argent. À partir de ce moment-là, vous dites à ces gens-là, maintenant, vous n'avez pas nécessairement d'hôpitaux, vous n'avez pas nécessairement de centres d'accueil, de nursing home. Alors, vous allez négocier avec le nursing home local. Vous dites, qu'est-ce que vous êtes capable de me donner? Ça me coûte combien? Vous négociez avec l'hôpital. Alors, voilà, vous avez, je termine là-dessus. Donc, il y a des grandes possibilités. Il y a énormément de modèles qui peuvent fonctionner à la condition que le financement soit local. Et ça demande la capitation.
I would have to comment that there's a slight circularity in your argument. In other words, il faut que ce groupe existe d'abord. Et on peut parler de financière, là.
Ouais. Ah oui, c'est ça. Il faut que ce groupe existe. Il faut que ce groupe soit reconnu. Mais en fait, dans l'expérience CIPA, c'est ce que nous avons fait. Bon, ça a été qu'une expérience, ça a été qu'un projet de démonstration, mais le ministère de la Santé et des Services sociaux ne voulait pas entendre parler de la capitation. Pourquoi? Parce que le ministère perdait le contrôle de l'achat des crayons de la part des hôpitaux. Les médecins ne voulaient pas parler de la capitation. Pourquoi? Parce que les médecins avaient peur d'être contrôlés totalement par ce groupe, et ainsi de suite, et ainsi de suite. Il n'y avait pas grand monde qui voulait entendre parler de la capitation.
François, I think we should move from this one, and there's a couple of questions that I'm going to raise.
Remember my illusion of control comment that I had? Psychotic control concept that I had? There we go.
Okay, no, I've lost the place. I think we're over at this mic.
Hello, my name is Elena Capral. I'm from the University of Ottawa. My question is directed to Ms. Sharkey. You talked about engaging other people and having outside perspectives on this issue, and I'm in complete agreement with you on this. So my question to you is, how do we engage those individuals in order to develop those innovative actions to get integrated care within our system?
Thank you.
Wow.
Shirlee.
I could have put you right out there to the mic. Actually, one thing that St. Eliz is doing, and I shout out the challenge to all of you, is we're putting together a session October the 16th on crowdsourcing. And 6 months ago, when I had a group of people at St. Eliz come in and say, crowdsourcing is the direction, we have to look at bringing people in, all of this, at the time I said, what is crowdsourcing? I've never heard of it. And it's a concept where you are bringing the outside world into solutions and problems, where we used to call it, outsourcing to now crowdsourcing, and many other industries are looking at it. So you are all invited to this session. We have 2 global speakers who are talking about how crowdsourcing has changed all kinds of realities in other industries, and to help us see how this could help us in healthcare, bring in new voices, new perspectives, a whole different way of engaging the collective. So thank you for that. And as I say, everyone is invited. We have this at the Sony Performance Center here in Toronto, but it's all going to be webcast. So hopefully we'll all learn what this method could be to help bring in more people to our solutions. It's but one method of hundreds and thousands, but I think this is where we have to constantly be changing. And just quickly, whenever we have questions, start with where we are. I go into a visceral reaction because I say to myself, the world is changing, just as we're talking here. And if we start with where we currently are, our starting point is already 10 feet behind. So there obviously is some wisdom to that and build on strengths. But I think it's how do we keep moving on the treadmill that's changing position on us all the time, and to do that effectively. If you don't embrace that, you're not going to have innovation, creativity, and new ideas. It just won't happen.
Thank you, Shirlee. Anything else? Good answer. Yes, in this microphone.
The question that I have is that we listen, but we really don't do anything with that. And what I'd like to know from the panelists is, what are your thoughts on how could we distribute some of the money to individuals and let them procure the services? And I believe that you would see integration happen so fast. And I'd like to know if there are models somewhere in the world that some are doing that, because I do believe that is a possibility that really should be looked at.
Okay, that's a straight question.
I would just say, actually, Gail, that does exist now in the health world, where people are purchasing services now, albeit they're in pockets outside of the hospital world and the insured Medicare world. But to your point, you know, when people have a choice and they are purchasing, the provider responds and very quickly becomes innovative, bundling things together. The sad part is we're doing that on the lowest end of activity, where you can get innovation, where we're trying to figure out, all right, how do we provide the nursing care, get the eaves troughs cleared, how to deal with food preparation and bundle all of that together, where people are trying to purchase. Imagine, you're right, if you could have that energy at a much broader sphere. So I think that there's some potential and interesting drivers of change that come forward when you look at it that way.
I've been ignoring microphone number 3.
That's okay. My question is related to case management. I do think that case management has an incredible amount of potential to help integrate, because frontline case managers know the needs of the clients, so they have a lot of wealth of knowledge. My concern from teaching lots of case managers is that they don't understand system thinking, like how to think broadly beyond the client. And secondly, that the social model is still a little bit distant from their thinking, that they tend to think in very much medical terms because the nature of people who are providing the case management services, that's their training. So I'm just wanting to know from the panel, in terms of what your experience is in terms of who should be providing case management. Like, is there a certain discipline that actually could think broadly about needs of people? And my other comment, I don't want to pass up on that. As a gerontologist, I feel my obligation to mention, I have great respect for you, Shirlee, but talking about older people and aging population as something to deal with, I find really problematic. I wish we would change our language and talk about supporting older people, engaging older people, whatever, but talking about them as something we have to deal with. As I get older, I don't want to be just dealt with. So just thought I would put that out there. Anyway, so my question is about case management. So
I don't want to be dealt with either, so I'm with you.
I can speak.
Joan,
Yeah,
go ahead.
thanks, Charles. I can speak to the case management provider, and this is a dialogue we've been having for several years at NCMN, and certainly case management is not a profession. It's a process and it's a role, and case management providers may be regulated healthcare professionals, depending on the clientele and the patient population. They may be non-regulated healthcare professionals, they may be family, and the example we hear most recently and talk about is with FNIH and their communities. You know the care provider is going to have to come from that community. And so it may not be a regulated health professional, but with education, I think people can provide case management. And I do disagree a little bit with you saying a lot of the case management providers don't have that system perspective, because as I talk to people across the country, they do. That is the role of case management, to balance the client and the system. And I think case management providers work very hard to dig and learn the system. But I do think the world going forward for case management providers will be, when I say the right provider, it may be a regulated health professional, it may be a family member.
Dr. Sawchuk?
think it's another issue of the value of the interdisciplinary team. I don't think any one member of the team is going to be able to do all of these components. The family doctor can't do all of the intricacies of the case management. The case manager maybe can't necessarily connect to all the other services that someone else on the team might be able to connect with. So for me, the question isn't potentially how much of this can the case manager do or not do. It's also the importance of who is supporting that case manager? Who does he or she have to connect with? What can the family doctor do, or the primary care nurse, or the other people to connect to all of those resources so that the patient gets that, but not from one member of the team, but from the collective action of the team?
I'll answer that. I think our work has been to really help for Canada to define case management, because people aren't understanding exactly what it is, or they're doing it and they don't know that's what they're doing even. So we hope to provide that knowledge base.
I'm going to recognize Senator Kean.
I'd like to challenge the panel with a question. How do we go about building the healthiest population in the world? We know that billionaires in our country outlive millionaires, who outlive doctors and lawyers, who outlive the poor and the dispossessed. We know that in some locations of our countries, the babies born today with a life expectancy less than 50. There are other parts of our country where babies are born with a life expectancy of close to 100. So how do we go about building a healthy population?
Thank you. Great question. That gets back to the point I made. By the way, in case I was misunderstood about my point on the same issue, the acute care health system is way down the list in terms of the determinants of society health. So that's the fundamental question of equity that always arises, and we tend to skip around. Anybody want to have a go? Dr. Sawchuk.
I think we know a lot about the determinants of health, and I think that as mostly healthcare people here, we ignore most of what we know. I mean, most of what we know about the determinants of health has to do with economics and not with healthcare. Mm-hmm. And in Canada, similar to our irrational connection with hockey, we have an irrational connection with healthcare, and we try and use our illness care system to help people be healthy. And probably everybody in this room knows that we cannot do that. We can help people who have health challenges to live better. That is our job. But our job, we don't have the tools. This isn't the area to help the population be healthy. Those are more in economic areas. My worry is we take too many of our collective resources and we pull it into healthcare, and we pull it away from health. And I think that having that conversation, do we even want to have, we were having this conversation last night, the healthiest population in the world? Is that even a value for us as Canadians? Or do we want to have an excellent world-class healthcare system or illness care system? And I'm not sure that those two things go together, because a world-class illness care system is very expensive and takes a lot of collective resources, and it pulls it away from somewhere. And we know where to invest those dollars, and it isn't with us.
Right to the heart of it. Yeah, that's right to the heart of the issue. Anybody else want to have a go at this one?
I just would echo that I do think this is where there needs to be an agreement on the vision. And I think the more we continue to, keep challenging on different sides, we're able to keep things the way they are. Because one argument is as good as the next argument is as good as the next argument, where I think there's not been that discussion to say, are we talking about the healthiest population or the best healthcare system? And I think it's the most important question of the day. The question in my mind is, how do we find the answer to that? And who's the one in control to answer it? That, in my mind, that's the other million-dollar question.
Yes, Joan.
One of the things I wonder about is, in any conversation, really taking time to think about who's missing at the table. And then there's certainly people that can't speak for themselves. And so I think that advocacy role of speaking for those people or helping those people speak for themselves, I think we need to do a better job of.
Okay, yes, François.
One of the big factors, as you said, is certainly income and assets. one of the variables which is really linked with health expectancy and health and etc. is certainly income. The big difference between the United States and Canada is our income distribution. Well, it was. On the le brut, how do you say le brut? Le revenu brut, total income, total individual income. Raw income, inequality in raw income in Canada is about the same as in the United States. The big difference is because of income tax. Now, who likes tax break here? You like tax break. Who think that income is a big factor in health, health equity, getting health equity? Well, I hope it's not the same. We'll raise their hand at the first question and the second. Because in fact, in Canada, since about 20 years, we've seen an increase in inequality in income essentially explained by tax breaks for the rich.
My question is around case managers, and I think that we all agree that they play an integral and important role in the healthcare continuum. I think we can also safely say that they're a key in the navigation of healthcare in many ways. But I'm wondering if we should broaden perhaps that scope, that it isn't just about a key profession, but rather that navigation, if we believe in principle on that every door is the right door for our patients and clients, there may be navigation or capacity building on navigation. It should be about peers, patients, consumers, the front desk person. So navigation belongs to everyone, and maybe it's investments in building capacity. So it's the nurse, it's the young person, it's my mom and dad, it's my child who's understanding how to navigate the system. So we're not creating another layer of expertise.
I need
and
you
there's
to
a
ask
question
the
there from the
question.
panel. So the panel question is, what do you believe we should build capacity around navigation?
Well, navigation is certainly one of the central roles we've identified in case management. Navigation's the new role out there because I think the public understands that word and they need navigating or they want navigating. I've just answered the question previously that there isn't a case management professional. There are people providing case management, and navigation is one of those roles, and that it could be all of the people that you've just talked about having access to the resources and the information, the time, the resources, and the scope to provide that navigation.
The only thing I'd add with that is maybe we need to open up our minds a bit to say what's the outcome we're looking for with navigation, and maybe we can design services with use of technology, with new approaches to have the outcome we're looking for versus the concern of the individuals and people in those roles. And that just may be another way of taking. That could be something that we put out to the crowd and say, help us figure out a solution to this.
Really briefly, there's a number of military here. Or I sat on the Gerontological Council of Veterans Affairs Canada on their 10 years of existence. And in the last year, we wrote a report named Keeping the Promise, where there was some proposal for the veteran on an integrated system, and navigating was one of the components of the system that we actually proposed. And we make a very important distinction between navigation and those in need of what we call intense case management and integration of care. And you have in this report a proposal for a full system of care for elderly people, whether they are at different level of health status and disabilities. Now the report has been rejected by not VAC but the Ministry of Finance, who actually look at the report and said it will cost money. Well, of course it costs money, but on the other hand, we were believing on the report that it would also save a lot of money, which the Ministry of Finance in Canada didn't believe in. So in fact, there are proposals, there have been proposals at the federal level also for a system that is actually, or could have worked for the veteran. And then this was also the idea of the report, and we were clear on this. This system, which would have been a kind of a highlight of the best practices in Canada for integrated care for the elderly and a whole system for the elderly, could have inspired the provinces to get into the bandwagon and implement the system. Now, the system was not implemented, but I think the report is still available on VAC.
Thank you, François. Now, unfortunately, time has caught up with us. I'm going to abuse the position of chair by wrapping up with a question for the audience, one which I would have liked to get to with the panel, but there are, in this world, high-performing, efficient, integrated care systems that work. Most of us know where they are. They're scattered, several in the States, several in other countries. My question is, what are the enablers? What are the unifying characteristics of these systems which have helped them succeed? And when you go down the list, what you find is a list of things which are often very distasteful politically to governments and professionally to organizations. To name a few, the whole concept of meaningful patient-centered care, of course, means working in teams, as we've talked endlessly. Scope of practice expansion in all non-physician practitioners in the system. Radical physician payment reform away from fee-for-service systems. Contracts with physicians, appropriate incentives and disincentives in the system. Powerful information systems, and an appropriate governance. And I put that last because I'm under no illusion that governance changes as we have experimented with in Canada, the regionalization. I'm under no illusion that these can work by themselves. My question is, are all of these things achievable by a bottom-up approach? How many of them require firm political action, public policy change, even legislation, and changes in current professional ethic? So something to keep you awake at night. I think this has been a very stimulating panel. I thank you very much for your questions.
Visit healthcouncilcanada.ca/symposium to watch more videos from the Health Council's National Symposium on Integrated Care.